And good morning, everybody. Thank you. Recording is now in progress. Thank you very much for joining us all this morning. There were two notes that I was going to make, and the first is about the fact that this press conference is being recorded and will be distributed to media outlets following today's press event. The second note that I would like members of the press to know is that I am using the term MPV today and not monkeypox in terms of terminology for the current outbreak. So once again, thank you all for joining us today as we discuss the worsening MPV outbreak in America and to discuss the urgent issue of funding needs now before the United States Congress. I am joined by Dr. Michael Fraser, who is the CEO of the Association of State and Territorial Health Officers, Lori Freeman, the CEO of the National Association of County and City Health Officials, Dr. Cesar Arias, who is a board member of the Infectious Disease Society of America, and Janet Hamilton, who is the executive director of the Council and State and Territorial Epidemiologists. I'm very grateful that all of you could join today's press conference. You are all heroes in the work of public health in the United States and have been on the front lines of responding to COVID, MPV, and so many other issues affecting the nation's health. I want to start out with the following comments. For the past 3 months, we all have been sounding the alarm, calling on the Biden administration to take action and allocate critical funding for the public health field and the STI field specifically. We have been battling a triple threat of public health emergencies related to COVID-19, an out-of-control STI epidemic, and an ongoing MPV outbreak. The STI field has been tapped specifically for community education, outbreak investigation, contact tracing, vaccine distribution, and clinical care through the nation's safety net STI clinics. Yet, for the past 3 months, we've been on the front lines pleading with officials for the support that our networks and systems need desperately to most effectively deploy our expertise. Because of this, our efforts to control the spread of MPV have been hampered. Now, with over 20,000 confirmed cases, we are reaching an inflection point. In recent weeks, a troubling vaccination gap has appeared between Black and Brown communities in rural areas and their white counterparts in major cities. We have seen this song and dance before. Without equitable vaccine distribution, we are doomed to repeat the failures and lessons learned from the COVID-19 pandemic, where we saw also unequal vaccination rates for communities of color. This was unacceptable then, and it is unacceptable now. We cannot take our foot off the gas simply because major cities have the means to mount a robust response, leaving smaller rural communities to fend for themselves. Rather, now is the time to accelerate our response and urgently fund state and local health departments, communicable disease programs, epidemiologists, and STI and sexual health clinics to combat this outbreak and prioritize public health. Today, we are joining a call to members of Congress to heed the lessons learned over the past 2 years. Our organizations, together with over 25 other national organizations, sent an urgent sign-on letter to the congressional leadership yesterday, defending the administration's ask for additional funding. And that funding totals a supplemental budget request of around $22.9 billion, of which $4.5 billion is specifically for MPV. There are additional requests for COVID and other needs of the federal government. Senate Republicans have criticized the decision, stating there was zero interest to include funding in this week's stopgap bill that is now being considered. We, those on the front lines of this public health emergency, I'll tell you very directly, have zero interest in repeating the mistakes of our country's past. That is our response. We are only as prepared as our healthcare system. And right now, the clinics around the country that are being asked to respond to this crisis are starved for resources. It is past time for Congress to act and allocate critical emergency funding to support the public health system and the response to MPV. Of this funding request, no less than $500 million does need to flow to STI clinics. We are in a race against time to stop the spread of the disease, and we need to empower our system, the public health system, our clinics and providers with the resources they need to get the job done. Without further ado, I am turning the podium over to my friend, Dr. Michael Fraser. Michael.
Thanks, David. Great to see you. Thank you all for joining us. And we really, as ASTHO, want to appreciate the leadership that David and his group and the partners on this call have provided in responding to MPV cases nationwide. I'm Mike Fraser with the Association of State and Territorial Health Officials. Our members are the secretaries, commissioners, and chief medical officers of the states and territories and state public health agencies. And earlier this month, ASTHO sent a letter to the White House highlighting the needs of state and territorial public health jurisdictions related to monkeypox response, of which there are several. And also in that letter, which was dated on August 24th, we asked the administration to release the Infectious Disease Rapid Response Fund as a bridge to address immediate needs of Congress, of states. The Rapid Reserve Fund was created to provide exactly what we're talking about here, which is bridge funding before emergency supplemental funding is released. So we are looking for resources for state and territorial health departments to continue the work, as David mentioned, of addressing health equity, of promoting vaccination campaigns, training, outreach, and public communications, providing the essential surge capacity needed to our state and local STI programs and clinics, providing surge capacity to laboratories, enhancing our surveillance infrastructure, and including funding for new epidemiologists, as Janet will share, engaging with community-based organizations to support culturally tailored education, and yes, even for administrating vaccines. While the vaccines are free to states right now, that doesn't mean they're free to deliver and administer. So there's a lot of cost associated with that. There are legal issues and administrative issues related to monkeypox that need to be addressed by state health departments, as well as IT upgrades. So according to our preliminary analysis and speaking with states and territories, we estimated somewhere between $500 million and $1 billion are needed today for our state and territorial response. Our members continue to tell us that while they have funding for COVID that has yet to be spent, that COVID funding is obligated for COVID. And ultimately, they have budgets and contracts and obligations for COVID funding that are specific to the continued COVID response. Monkeypox is a new response. There's a degree of flexibility that states have been given by their federal project officers, but they're not going to meet the needs of states, certainly for the medium and long term. And there's a number of issues related to using COVID funding for monkeypox that are both statutory, but also in the federal programs themselves and the way that states have to administer them. So we urgently ask Congress to consider the needs of state and territorial health agencies in their monkeypox response, as we'll describe today, as well as urging the administration to release the Infectious Disease Rapid Response Fund to states so they can, again, deal with some of these immediate pressures while Congress develops its supplemental emergency request. Thanks, David. I'll turn it back to you.
Thank you very much, Mike. Lori Freeman, who's the CEO of NACCHO, the floor is yours.
Yes, good morning. Thank you so much. There are nearly 3,000 county and city health departments in this country who fight every day with all that they have to keep the communities that each of us lives in safe and healthy and free of disease and other threats to our health. Long prior to the COVID pandemic, our health departments were straining under the weight of disinvestment in prevention and public health, resulting in upwards of 20% plus reductions in our public health workforce in our local jurisdictions alone. The pandemic also greatly exacerbated these strains, as well as, again, illuminated the need for our country to prioritize investing in the prevention of disease, along with keeping other threats to public health at bay. Local health departments are once again finding themselves on the front lines of an infectious disease outbreak with the monkeypox response in their communities. They are vaccinators and testers. They run STI clinics and local HIV programs, and they link people to needed treatment and resources. They focus on populations who need support because they already are disadvantaged due to social, economic, and other environmental factors. The communities are vulnerable already and desperately need the programs and services from our local health departments. Our local health departments convene and partner with local community groups to reach those most impacted and to educate the healthcare providers on what to look for to ensure timely diagnosis, testing, and treatment. And they work with the individuals impacted to help them adhere to care, including providing housing and other supports when necessary. Of course, this is the work that they have dedicated their lives to as public health leaders. But this unique and new disease threat and the response required for it simply cannot be sustained without resources, including funding, vaccines, supplies, things that the administration's emergency supplemental requests would provide. As a nation, we need to show our support for this critical work on the ground by making the emergency supplemental request a reality and quickly moving those resources to the front lines of this response, to our deeply rooted local health departments and other key partners on the ground that are necessary to get us through this in communities. At the local level, the monkeypox response is on top of the COVID work, as well as other more localized challenges like the polio reemergence, wildfires, floods. With close to 22,000 cases now in this country, and every state and many jurisdictions facing cases, we must act now to address this outbreak and to stop it. We need adequate vaccine supply, testing, supplies, and treatments. We need to make sure that the uninsured have the coverages that they need to get if they get exposed or get sick so that we can contain this disease. Supplemental funding is critically important to move forward. In many ways, the initial and easy work has been done. Now local health departments are needing to be more creative to reach more deeply into their communities, hardest to reach with messaging, education, vaccine, testing, and treatment. This supplement is not for tomorrow, it's for today. We need to control the outbreak here in the United States and focus on the elimination of this outbreak. These additional funds will allow us to do more to contain the disease and to get those impacted the help that they need. Back to you, David.
Thank you, Lori, very much. Dr. Arias with ISDSA, please take it away.
Thank you very much, David, and thank you everybody for allow us to participate. My name is Cesar Arias. I am a board member of the Infectious Disease Society of America, and I serve as Chief of Infectious Diseases at Houston Methodist Hospital. I am reporting what we are seeing from the front lines, and as a practice physician and infectious disease clinician, I'm reporting exactly what we are experiencing right now. The response for the current MPV outbreak, like any infectious disease response, must be a partnership between public health and healthcare workers. As a frontline healthcare worker, we know that our resources, healthcare systems, were already under-resourced before COVID-19. And in the past 2 years with the COVID-19 epidemic, we are now confronting a new threat, which is MPV, this MPV outbreak. We, as infectious disease physicians and healthcare providers in the front lines, continue to give all what we have here to serve our patients, but we need more resources in order to meet these needs. Indeed, we need to expand access to vaccination, evaluation, including diagnostic testing and treatment. Despite some significant improvements in testing capacity, we still hear far too many examples and stories of my patients that struggle to get access to testing, either because there is no enough providers that can do this, or because they can't afford it. We need to ensure that testing is made available with zero costing sharing, particularly in these underserved areas that are seeing these patients, regardless of insurance status. Despite a more streamlined regulatory process for prescribing tecovirimat, which is TPOXX, the drug that is used against MPV, there is a lot of a struggle to try to get this treatment and access to these patients. Indeed, several of our providers are not familiar with this process and are fearful about a process that requires informed consent for these patients. So it's very time consuming. There are no mechanisms or resources to support the substantial additional clinical work that involves isolation of patients, cleaning after the patient is seen, and coordinating all the paperwork, and follow-up clinic visits that we need to do with this patient in order to fulfill all the paperwork that is needed. Therefore, there are very limited clinicians that are able to truly prescribe this unless they have enough resources and expertise to care of this patient, leaving many gaps in access for treatment for these patients. And this is really becoming, on top of the COVID pandemic that we're experiencing, a really stretch for our resources and our patients. So we do need resources. We as frontline clinicians need these resources for the academic medical center, Ryan White clinics, community health clinics, and STD clinics more in big cities and rural areas where these patients are being seen right now. So as a frontline clinician, this is a very important issue, and I'm very happy to be able to express our views from the Infectious Disease Society of America. Thank you very much. Back to you, David.
Thank you, Dr. Arias. And last but not least, my friend Janet Hamilton from the Epidemiologists. Janet, please.
Great, thank you so much. I'm Janet Hamilton, the Executive Director of CSTE, and we represent those epidemiologists that work in state, local, tribal, territorial health departments. Essentially, CSTE, or the Council of State and Territorial Epidemiologists, represent those disease detectives that are responding to this MPV outbreak, COVID-19, Zika, measles, and any other current or emerging disease threat. CSTE adds its voice in support of the National MPV Working Group's efforts to ensure that the White House request of $4.5 billion for additional funding is included in the current budget negotiations and activities. This funding is crucial for our continued national response to the MPV emergency. It is a move and a recommendation towards more sustained and predictable funding for public health, especially during emergency responses. And what I will say is, prior to COVID-19, public health was chronically underfunded, which resulted in a public health system that was unprepared for the global pandemic. And with MPV, we are seeing the same mistakes. A system that has inconsistent funding, insufficient resources, and while our workforce is resilient, it's also exhausted, and we're continuously asked to do more with less. Disease outbreaks and investigations are complex. It's that simple. They take putting together many different pieces and parts, and it can only be done optimally with the right funding and resources in place before the response. But then in situations like this, where we don't have what we need, to get that critical funding available as soon as possible. Funding is needed, as you've already heard, across the board, and I really want to highlight that it's needed to ensure the rapid receipt of data from healthcare and our coordinated public health infrastructure. We need to be able to support implementation of dashboards and data visualizations, to publicly display data, to timely share the information around cases, including their demographic information, and to also be able to submit that data to CDC around cases and contacts in the required formats. Additionally, we need funding for epidemiologists, those individuals to do case investigations, to clean the data, and to do other types of investigation type activities. No state has specialized MPV epidemiologists. And prior to this outbreak, CSTE had estimated in our epidemiology capacity assessment that we already needed an additional 2,196 epidemiologists to deliver the most basic public health services in state health departments. So again, even before MPV, we needed funding. Now we're being asked again to do more with less. This funding comes at a critical time, and we ask for your support of these funding activities. David, I'll turn it back over to you.
Thank you very much, Janet. And Stephanie and Elizabeth will now facilitate any questions coming in from members of the press. And so please take it away.
Thank you all so much. As I mentioned at the start of the press conference, if you have questions, please either raise your hand in the chat or drop a question in the Q&A and cite your organization and your name, and you will be called on in the order we receive the questions. The first question I have is from Krista Marr. Krista, I'm going to unmute you.
Thank you so much for taking my question. I have two questions actually. One is the monkeypox response, pulling funding from, clinics' ability to respond to other STIs right now? That's one question. My second question is following up on a point that Janet made. The CDC's vaccine administration data is only from 34 states and 1 city right now. And I am wondering whether the funding issue that you just mentioned, this might not be, I'm not sure who to direct this to, but I'm wondering if the funding issue that you just mentioned was part of why we don't have data for several large cities and states on vaccine administration data. Thank you.
Great. So I'll answer the question about STI clinics, and then Janet and others can comment on data systems. First of all, MPV is severely impacting STI clinics and their ability to respond to the broader STI epidemic. Prior to COVID, we had record high numbers of sexually transmitted infections in the United States. And when I say STIs, I'm talking about the federally reportable STIs: syphilis, gonorrhea, chlamydia. HIV is an STI, of course, separately reported to the federal government. STI clinics do not have a federal funding stream. So they exist by putting together patchwork pieces of funding from local county health departments, private sources, and other revenue streams. MPV is shining a bright light on the fact that this safety net provider of clinics, safety net clinics who provide essential services, are in desperate need of federal support. So there's three problems going on. We don't have a federal funding stream for them. MPV is inundating these programs, and it is interrupting our ability to diagnose and treat other STIs. The same phenomena happened during COVID, which made the STI epidemic in America worse. Janet, Mike, Lori, do you want to take the question on data?
Sure, I'd be happy to start. I mean, I think, Krista, the simplest answer is yes, there's not enough funding to support the data systems, and yes, we need more. So whether it is being able to adequately track the vaccine administration information for a new vaccine, a new delivery mechanism, these systems that we put in place for COVID need to be built upon, but they also have to be modified. And then the information, as you mentioned, does need to be submitted onto the federal government for aggregation. But all of that takes time, energy, and resources to both modify data systems get the information in, as well as then be able to submit it in new required formats. So absolutely, I mean, we don't have what we need. We didn't have what we needed before the response, and now we're being asked to do additional sets of activities with no additional resources.
Thank you so much.
Thank you, Krista. Next up, Michael Staub with the AP.
Hi, thank you for taking my call. A couple questions. First of all, Mr. Harvey, at the beginning, you talked about the worsening MPV outbreak. The available information on the epi curve seems to suggest that the number of new cases has been declining for weeks. I just want to make sure I understood what you meant when you say it's worsening, just simply the fact that there are more cases each day, even if they're a smaller number. And then wanted to ask Ms. Hamilton about, you said something about there are 2,196 epidemiologists needed in state health departments. What's that would be on top of, how many are there right now? Thank you.
Great. So I'll start. Michael, thank you for your question. Yes, we are seeing a leveling off of diagnosed cases. That does not mean this outbreak is finished. The good news is that the leveling of cases from available data, it seems to point to the fact of behavior change. And we're all very hopeful about the effectiveness of vaccines. But to stay the course, it is very important for us to continue to invest in the response. We have gaps in vaccine distribution. This outbreak is moving around the country. We're seeing more cases in rural communities. So we are far from over. There is some hope around these cases leveling off. That should not give anybody solace that this outbreak is done. It points to the need for a continuing investment. We still have to ramp up our efforts to respond to this outbreak. And there are many, many data questions, clinical care questions, research questions that remain to be answered about this very unusual outbreak of a known virus over the decades that is presenting itself very differently in the United States. So we are far, far from ending this outbreak, unfortunately. There is some hopeful news, but we cannot rest on our laurels.
So David, if I could just
Please,
follow
Cesar.
up with that, I think it's very important to understand that we still have a lot of underreporting of cases. And in the front lines, we know that there are very unusual presentations of this where clinicians may not recognize that this is actually monkeypox. As these networks and close contact with people increases, I believe there is a lot of underreporting, and as we learn from COVID, it's very far to predict when this thing is going to be over. So we don't want to be unprepared and go through the same pain that we've been doing with COVID. I think this is a very important lesson that we need to learn.
Could I add here too, David, please, that, even if there aren't active cases, the work of public health actively continues to both educate, get providers trained, get them ready for cases, and ensure that we are providing good community education to the public, and have systems in place. So even if cases are stabilizing or declining, there's still work in public health to do to continue to mitigate the disease. And let's hope that the mitigation strategies that we're currently using are helping to flatten that curve a little bit as well.
I'll just respond to the epidemiology needs. So every year, sorry, not every year, but on a regular basis, CSTE has done an epidemiology capacity assessment. I'd be glad to share that with you. It's posted on our website. The last one we did was in 2021, and we assessed the epidemiology needs in state health departments. So this excludes the epi needs at the local level. And we identified that we needed an additional 2,196 epidemiologists. So I don't have the full number of epidemiologists working across the spectrum, but the assessment from state health departments was that level of need just to deliver the most basic resources. So we certainly think that many more epidemiologists are needed across the public health infrastructure to fully be able to achieve public health transformation.
Thank you all, and thank you, Michael. Up next, we have Ariel Dreher from Axios.
Great. Thank you so much for taking my question. I think if a couple of you could respond to this would be awesome. How do we expect monkeypox to spread on college campuses this fall? I know students have just returned to many campuses. And do colleges and universities have the testing, treatment, vaccines to serve students, or will they need to be partnering with local public health and sexual health clinics? I'm curious if those partnerships have already formed or in the works, but thank you so much.
Thank you. I
Great.
think we should start by asking Cesar and Janet to comment, and the rest of us can fill in.
Yeah, so as the epidemiology and transmission of this virus is clear, this spans to close contact and sexual networks. So as more people get together, any of these different infectious diseases probably is expected to increase and recognize more cases. I don't think at the moment colleges or universities are prepared for testing and capacity to handle this or administer vaccines. And this is also part of the response that we need to address. The coordination with really staff public health systems across the states will really prevent sort of major universities or major colleges to be able to start programs with the public health system unless there is specific funding to address this. So this could be a very important point when there is an introduction of this virus in these sexual networks or in colleges when there will be close contact coming out from the pandemic.
I mean, I would just add, I think if you look at the way that we see MPV being transmitted, colleges and universities are certainly one place where there's potentially a higher risk population, but it's not the only place. And I think that's why the coordination with state, local, tribal, territorial health departments is so critical, whether it's for populations at risk in colleges and universities or populations at risk in other settings. So I think that's the important piece to emphasize. In all settings where individuals are at risk, really need to take the opportunity to get prepared and work with their state, local, tribal, territorial health departments. That's why we're essentially calling for this additional funding to be able to support that kind of close collaboration and engagement when we do see introductions of cases, and also to prepare and ensure that we're able to get vaccine administered to all those different types of high-risk populations.
So definitely, this is Mike Fraser from ASTHO. I think that I know anecdotally that many state secretaries of health are speaking with their education partners. The back to school time is big for lots of vaccines. Meningitis is another. So I know that those conversations going on, but as mentioned, the resources that would be needed to stand up any significant response on campuses would be limited by resources that are available now, and also probably by vaccine supply, depending on how large those outbreaks would be. And part of what the administration is asking for is money for vaccine, which we will need potentially, as well as the staffing and all that goes around administering a vaccination.
And just to close out on the engagement with local health departments, county and city, and institutes of higher education, other educational settings, our health departments are always there working with those settings on keeping their students safe and healthy. We have a lot of good lessons learned from COVID in institutes of higher education and schools. you're working closely with their local health department partners to stand up whatever is necessary to address those populations. I would agree with Janet. There are other unique settings that that perhaps may need to take priority due to higher risk, but I think we have to follow the risk and really protect those people that become or that are in settings that have the most risk. But that doesn't preclude a college setting if we have an outbreak there.
Thank you all, and thank you, Ariel. We have a question in the chat from Pian Wong at NPR. What critical information are we missing right now about MPV that would help steer the response, i.e. how well the vaccines or treatments work? Will the proposed funding help fund research to answer these questions?
I'll start out, but others will have very specific comments to offer. We're missing a lot of data. Vaccine effectiveness, asymptomatic transmission is a big concern to many clinicians around the country. There's a study going on around that. We're in clinical trials for TPOXX, just entered the third phase of clinical trials for TPOXX, which is of course the desired treatment for people. So there are a lot of questions, there are a lot of data that we still need. Cesar, would you like to comment further?
Yeah, I want to emphasize that this outbreak is quite different from what was called endemic MPV in Africa. So I want to emphasize that there are several presentations of this that really stunned us in the field, that we don't recognize as part of the syndrome, and we're recognizing as this. So all this information, for example, the effectiveness of TPOXX is still not clear, and that's the reason we are launching a clinical trial now. But we are doing that because that's the best we have, and there is some experience in the past. So there's likely that it's effective, but how effective it is and how safe it is, we still don't know at greater scale. And the vaccine is the same situation. So a huge amount of data will be needed to be able to tackle this comprehensively with the challenge that is presented at this point for clinicians and public health care workers.
There is 200 million for high priority research in the administration supplemental asks that we're supportive of. So that's a start.
Great. Thank you so much. And I think we have time for one more question. And I see Mike Staub from AP has another question. Go ahead, Mike.
Yeah, thanks. Sorry to go again. I appreciate you taking it. I just wanted to ask a couple. First, Mr. Harvey talked about the out of control STI epidemic. I wanted to make sure the 500 million that you requested, will that help that work, or is it going to be, is it siloed money just for monkeypox? Also, I wanted to ask, what are you guys seeing in terms of the demand for vaccines? Are the lines still as long, or are you seeing somewhat of a diminished demand? And last, LA County in California last night said that they had a death that they were ascribing to monkeypox. I just wanted your take on the significance of that. Does it change how we think of the outbreak? What's the significance of that in your eyes? Thank you.
I'll start out with some comments, and then Cesar, I'll shift to you, and then others can contribute, because Michael, you asked some very good broad-ranging questions. The first is that allocating no less than $500 million for STI clinics, yes, will obviously improve this safety network provider of services with increased capacity to deal with MPV and other STIs. Because let's not forget that when you're diagnosing and treating MPV, you also have to diagnose and treat or rule out other STIs because of how MPV is presenting itself. It's a down payment is the word I would use. And then ultimately the next phase of this is to look for permanent funding streams from the US Congress to support STI clinics. Vaccination rates have evolved. I think, as we all know, there's been coverage about that recently. In the words of Dimitri Daskalaskis, who is the deputy monkeypox coordinator in the White House, He has said very eloquently, the real work starts now. We have to distribute vaccine in very specific, creative, and new ways to bridge the racial divide, an ethnic divide in this country, and to reach communities at risk. And that is hard work. It's resource intensive work. That's why Congress must pass this additional funding. Cesar.
Yeah, I just wanted to comment about the last point. And it is clear that there are complications that are life-threatening with this virus, with inflammation of the brain, for example, encephalitis, inflammation of the lung, called pneumonitis, and also, very high risk for pregnant women, particularly for preterm pregnancies and fetal death. So we had also an announcement about a week ago of a death here in Harris County in Houston, Texas. So there, it is unclear if this is directly related with MPV, but it's definitely, this is something that, is being well known that it could be fatal complications of this infection. As children get involved in this, this seems to be really bad for children as well. So it is not a simple disease. Apart from the massive problems that we are seeing in the current presentations, the presentation that could be really dramatic can be seen, and it's important to bear that in mind.
And Cesar, I'll just add to, because Michael, you asked about this very specific situation that emerged from Los Angeles. It is clear that this death is attributable in part to the immunocompromised status of the individual. So we know people who are immunocompromised, people with HIV and other conditions, are at risk for worse health outcomes from getting an MPV infection. Cesar, I don't know if you want to say anything more about that.
Yeah, so we do have a large population of immunocompromised patients here who are transplanted or cancer patients. Any viral disease in this patient could potentially be fatal if disseminated. It's difficult to treat. Vaccines are not that effective because they cannot mount a response. So there is a very important immunocompromised population in the United States, not only because transplant cancer, but with chronic diseases that will be at high risk for this infection. And if this outbreak continues to be sustainable, it's likely that those populations will be affected as well.
So Michael, this is not a benign infection. This death is very concerning to all of us. We have to stay the course. We have to monitor this, and we have to be very concerned about the broad-based, health of all Americans in relation to this outbreak. Any other comments coming from our speakers? Okay.
Great. Well, I want to thank everybody for joining us here today. As David mentioned at the outset, we are recording this press conference and plan to send it out to participants a little bit later today for your use. If you do have any other questions, please email us. We'd be happy to answer them. And once again, thank you so much. I hope everybody has a wonderful day.
I want to thank all of our presenters. Thank you so much for being with us today. And thank you, members of the press, for covering this issue. We deeply appreciate your work. Thank you so much.
Thank you very much.
Thank you all.